Hi, my name's Annabelle Crabb and I'd love to welcome you tonight to the latest breast cancer trials Q&A. These are regular events for those of you who have joined us before. This afternoon we've got the revolutionary element of a live audience. We are coming to you from Hobart and day one of the Breast Cancer Trials annual scientific meeting. I'm quite excited because I rarely get invited to scientific meetings and I'm thrilled to have not only a live audience but a live panel and a slightly elevated potential for mutiny, which I'm sure will crush brutally when required. However, it's great to have this collection of talent, knowledge, experience, both on the panel and in the audience. And we'll be running through some incredibly perceptive and important questions that have been submitted by those of you who are joining us online, of whom there are at least 1,500. So welcome to you all and thank you for joining us. We pay respect at the beginning of tonight's proceedings to the traditional custodians of the lands around Australia and New Zealand and from wherever you might be joining us from. And most specifically, of course, here in Hobart, we pay respect to the Mawunnuna people and their ongoing connection to the land, sea and community. As you know, you may know, but I'll remind you, Breast Cancer Trials is the largest independent oncology research group in Australia and New Zealand. They've been conducting clinical trials research into the treatment and prevention of breast cancer since 1978 with some extraordinary advances and results. Tonight, our panel of experts gathered here for the scientific meeting will be answering your questions about supportive care in breast cancer. We've covered a lot of topics in these Q&As over the years and I never ever fail to learn something extraordinary and I look forward to it, to discovering these together. As I mentioned, we have a live panel situation. I'm going to introduce them to you one by one. The first one to my right is, I think, possibly going to be the most troublesome one. She's extremely jet-lagged, very chatty, and possibly a heckler. Just telling you like it is. Dame Leslie Fallowfield, who's a professor of psycho-oncology at Brighton and Sussex Medical School at the University of Sussex in the UK, where she is the director of the Sussex Health Outcomes Research and Education in Cancer Group. Yes, this is a plot to make me say Sussex 3 times in one sentence. Welcome.
Thank you. Hello. And I'm not trouble, I'm just jet-lagged.
Even more confusingly, we have a second Leslie on the panel, Leslie Gillam, who will be known to you. She's joined us before. She's just here in the green cardigan. I'm just indicating her like a flight attendant indicating the exits. Leslie is the chair of the Breast Cancer Trials Consumer Advisory Panel, which does incredible work and very powerful work directing the research of this organisation. Leslie was a participant in the TEXT clinical trial and has a personal history of breast cancer. Lovely to see you again in person, particularly, Leslie. Okay, over to this end of proceedings, we're joined again by Dr. Belinda Kiley, a medical oncologist from Campbelltown and Concord Hospitals. Belinda specialises in the treatment of breast cancer and is also the principal Australian investigator of the Optima clinical trial. Welcome, Belinda.
Welcome, thank you.
Just here we have Kathleen Dower, who I'll call Kath from now on, I think, who's a senior radiation therapist at the North Coast Cancer Institute at Lismore Base Hospital in New South Wales and is a 2025 Breast Cancer Trials Clinical Fellow. Lovely to have you here.
Thank you.
And second to last, we have Professor Lisa Beattie, who's a professor in clinical psychology. Oh, hello. No, you're over here. You'd think I work in politics, I should know my lefts and rights, but I don't. Please forgive me. I'm also jet-lagged. No, I'm not. Professor Lisa Beattie is a professor in clinical psychology at Flinders University. She's a fellow South Australian and a visiting consultant clinical psychologist in medical oncology at Southern Adelaide Local Health Network. Welcome. And finally, we have Dr. Cindy Tan, who's an early career researcher and dietitian specialising in cancer nutrition at Concord Cancer Centre, Concord Hospital in Sydney, and is also a 2025 Breast Cancer Trials Clinical Fellow. Welcome. Okay, so there are thousands of people listening in to this session, and I know as ever we have a large audience of people who have experienced breast cancer, who are at some point in that experience, and there's also friends and family who are very keen to learn more, and that's why we gather these fountains of expertise, just so that that becomes easier. I'd like to thank everybody who's sent in questions and is watching tonight, and I'm going to crack straight into some of those questions. Okay, now, Belinda, can we start with you? Can you explain what supportive care means? We have been, I use the term supportive care very casually as I introduce this session, but I mean, we assume that all care will be supportive. What do we mean specifically by the term supportive care?
I think that's a great question to start with. So I think when I think of supportive care, what I think of is all the things we do to try and help people feel better. So what can we do to help their symptoms from the cancer, minimise the side effects from the treatment, help their emotional well-being, help their physical well-being. So there's so many different things we do, I guess, when we're looking after people with breast cancer. It's not just about giving a medication, it's making sure we can do everything to make sure that person's quality of life is as best as possible and make sure that they're living their best life, essentially. What can we do to make the whole journey better?
So I guess it's partly about making a person's experience better, which is obviously worth it in itself, but does it make it easier for the clinical treatments to be effective if you have somebody who feels confident and knows what they're doing and doesn't feel as though they're being surprised every step of the way?
Definitely. So I think people do a lot better, we know, if they're well supported. So if we're giving treatments, discussing the side effects, doing things to minimise those. If they're getting a lot of symptoms from their cancer, making sure we're doing what we can for that. If they're struggling with anxiety or worried about the cancer coming back, ensuring they've got the psychological support they need. So there's really a whole stream of things, palliative care and helping people prepare for the end of life. Like, there's a lot of different things we do to help support people.
And what are the main items that people ask about, even if they're not sure exactly how to ask about them?
I think psychology is a big one. I think the whole cancer experience is just so stressful for everybody. So I think a lot of people ask for support. I think diet and exercise is another big one, particularly for our women coming through with breast cancer. There's a lot of sort of myths out there about what you can and can't eat when you've got breast cancer. People will tell you things that they think are helpful, but then it gets very confusing to know what to do. So I think the diet and exercise advice is another big one people often ask about.
So if you assume that the breast cancer journey begins when you receive the news that this is part of your life, is there a point at which supportive care kind of kicks in? Is there a starting point? Or
I
is
think
that
it
the starting
starts
point?
right at diagnosis. I think that's what we should be aiming for, that as soon as I meet that new person, we need to start to think, what can we do to help this whole person? They're not just a breast cancer, they're a person who comes with all these other attributes, and we need to do everything to sort of manage that as well as their cancer.
I guess that any patient's immediate thought will be a clinical one, right? I mean,
Yes.
with just brutal questions about exactly what this means. And do people explicitly generally think about their need for supportive care, or is it something that needs to be encouraged by?
I think a bit of both. I think it's a gradual sort of introduction of a lot of this. So we're seeing people regularly. We work as a team. I think that's the other big thing in oncology. We've got a team of people that are there to help. So I think maybe one of the first things I'll be doing is like letting people know that we have a team here to help you get through this. And yes, often that first consultation is about, what does this mean? Am I going to die? That's common where it starts, but then there's a lot that then starts to happen as we meet people and go through their treatment, and they meet other members of the team, and we make them aware of what's available. So I think sometimes people just don't know what help is out there.
Okay, so I'm going to go to somebody who's been at the non-clinical end of that discussion. Leslie, I feel like Australian Leslie, I should be clear. I feel like I've been asking you about your breast cancer journey a few times, but you're so good at talking about it, so I'm going to go there again. Can you just share a little bit of your story about where you were when you were diagnosed with breast cancer?
So I was diagnosed back in 2009, which is quite a while ago now. And so I was considered young at the time, at the ripe old age of 45, don't do the maths. And yeah, so it was like a complete shock. It came out of the blue. It was very confronting. But as Belinda touched on, I was fortunate enough to be referred to somewhere that had that team already in place. And after the initial discussions with the surgeon and what we were going to do there and all that sort of thing, I then met my oncologist, and that's how I became involved in the research. But I was diagnosed with early breast cancer, and it was hormone receptor positive. And I proceeded to have surgery followed by radiation therapy, and then I was introduced to the prospect of going on to a clinical trial, and that involved it was a double-arm trial looking at what was current standard of treatment versus a new treatment, which was an aromatase inhibitor, which is now sort of standard of care. But because I was young, I had to go through menopause overnight, and so that was quite impactful, and that's obviously, relates to supportive care and a lot of side effects and things like that.
Okay, so that's an enormous amount of stuff going on in your body and your brain in a really short amount of time. Mm-hmm. I reckon even when things are going well, it's hard to kind of sort out, do I need a bit of support and help? Like, just even being busy is bad enough. Yeah. But when you've got all this stuff going on, how explicitly are you able to think about ancillary support that's not just about the clinical crisis that you're confronting?
You don't really, to be honest. Like Belinda said, the first thing you want to know is, are you going to still be here with your children or, with your family or whatever? I think in my situation, the fact that I started on a clinical trial, we collect patient-reported outcomes, which are basically monitoring your quality of life, your side effects, all of that. So that allowed me, obviously, access to supportive care earlier than I probably would have considered.
So people are asking you explicit questions to monitor all this stuff, which makes you think about it.
And I think, they're such an important part of a clinical trial because they lead to what happens in clinic from day to day. So, if there's a side effect related to a drug, then they can, because of what's being collected in that trial, they can work on ways that they can help the general population in that space.
If you've got kids too and you're managing the reactions of people around you who depend on you, who are also getting this news in real time, is there a tendency, I know you've talked to so many women, is there a tendency to kind of put yourself in the queue behind managing the emotions of people around you?
I think I was personally good at managing the children's situation, other than Belinda hasn't got in that they need to work on how they're going to tell the children on my behalf, because I found that really difficult. Yeah. But I think I managed their situation. My husband was the one that got pushed to the side. I just didn't have enough time to focus on how he was coping with the diagnosis. And I think we sometimes forget about supportive care for our family and our friends and partners.
Okay, so that's a really great point. And you discovered this through your participation in a clinical trial. What elements of that support were the most important to you, keeping in mind that I guess people have different experiences, but what did you find the most valuable?
Yeah, well, I think being on a trial, you quite often have to go to clinic a lot more than the average patient. So I had that support network of my trial team a lot more. And so it was just, I always say the hardest day I had 2 hard days, really hard days, the day of my diagnosis and the day I had to leave my trial team, because they become part of your family. So they were probably the biggest support for me, and I actually didn't access too many supportive care services, but I did take the advice of my oncologist, who suggested I buy a dog, who then became my psychologist. He became my exercise physiologist. I can't say became my dietitian, but yeah. But I took whatever advice was given to me, and then had the ability to access it from there.
Great, thank you, as ever, for your insights. I'm going to go next door to Lisa, who I'll remind you is a professor in clinical psychology at Flinders University. I won't read out the rest of her CV, but that's her area. Lisa, what are, from your perspective, some of the commonest emotional and psychological reactions to that first worst day, the one where you get the news?
I mean, I think that it's really hard to narrow it into the most common, because we know that breast cancer diagnosis has a really huge pervasive impact on so many different areas of people's lives. It really is a huge disruptor. I think some of the most common ones that I've worked with women around over the years have been around things like anxiety. So whether it's about anxiety for their own future, anxiety for their family, some of the anxiety could be quite specific, even around having needle phobia or getting through various scans. Scanxiety is something that's come up as a term over time, because the fear of what the next scan might show as well. So there can be quite specific fears, but it can also become quite generalised, the worry that people might experience too, where they just start worrying about a whole heap of different areas in their lives, about how work's going, what's happening financially for them. There's been just so many different impacts there. So that's sort of some of the anxiety. And then probably the number one anxiety that we do tend to hear about from a lot of people, even from the point of diagnosis, is actually about the fear of recurrence or progression. So whether or not this cancer will come back at some point or spread to another part of their body. And that is often cited as the number one unmet need that people want some support around. So they're kind of some of the big ones. And then outside of that, there's also, for a lot of people, perhaps it might start because they're physically not feeling too well to start with. There can be a bit of a tendency to withdraw. They're not able to connect as much with their normal social network, and they can start to feel quite isolated quite quickly, and that can also then start to spiral into feeling quite low or depressed. So they're probably the most common emotional, psychological reactions that we see. But again, similar to what we've already heard, concerns for loved ones, the impact on them as well can be really quite profound. Concerns for children, yeah.
And I'm just thinking about Leslie here, who had that appointment and got the news, and then shortly thereafter was in menopause at 45. How do the physiological symptoms kind of spiral into the psychological outcomes?
Yeah, it's an interesting one. I think sometimes there's the actual physical symptoms, and then there's the impact of those symptoms and having to live with them, that you end up having. I've often called it like a donut. There's the initial physical symptoms, and then there's the suffering caused and the impact of them that it actually exacerbates how severe those symptoms might be for people as well. And these symptoms can really stop people from sticking with their treatment too, their ability to adhere to the treatment. So it is really worth focusing on.
And we've talked in past sessions about all of the unanticipated symptoms around libido, around diet, around how you can exercise and all of that. I want to hear about the Finding My Way programs and about your work on this particular resource.
Yeah, sure. So basically, in response to being this awareness of what a profound impact breast cancer has, we know that so many people need to see a mental health clinician, but we also know that there's a massive shortfall. This goes across the board in any area, but particularly in psychology, in cancer, there's just not enough psychologists or mental health clinicians to meet the need. So we've got an increasing population of people who, with this increasing need, and just not enough people to be able to provide services. So to address that, over the last 20 years, it's quite a long time now, I've been developing more accessible ways of providing evidence-based resources and self-management strategies to people so they can self-manage their distress. So the Finding My Way programs, we've developed 2 of them over time, and they're 2 online programs that are really designed to help address some of the most commonly experienced psychosocial needs. So one of them that we've developed is for early stage cancer, and then the most recent one we've developed in partnership with Breast Cancer Network Australia, is one for women with metastatic disease as well. So yeah, it really does cover from the point of diagnosis right the way through what are the most common physical symptoms, coping with emotional distress, coping with changes in identity, body image, changes in social networks as well. So it really does cover what are the most common things that come up, and also, more importantly, what are some strategies you can put in place to address that. And the key thing is, because it's online, people can do it at their own pace and place. So you don't have to attend yet another appointment.
And how long do they take? Where can you find them? Are they free? Is there homework?
Homework is always such a dirty word, isn't it?
It is.
So yes, they are free. So the original Finding My Way program, we've trialled that over many years. That's now completely freely available to the Australian cancer community, or overseas if people wanted to. Each of the programs have got about 6 modules in them. People can dip in and out, use as much or as little as they like. So we do recommend roughly a module per week, so that you're not getting completely overloaded with information in one hit, but it really is up to people to tailor it. The metastatic version, we're currently finalising a clinical trial for, and we've launched a new trial. So for people who want to use that one, they need to sign up as part of a clinical trial. So did I miss anything?
No.
Oh, there is homework, yes, but it's up to people how much of that they choose to do.
Optional homework.
Optional
Very
homework.
best kind. Okay, so sometimes when you know a field very well and you've dealt with lots of patients and you sit down and you try and codify what you've learned, you learn more about what you've actually learned in doing your job, right? Am I right?
Absolutely, yes.
What became clear to you when you were putting these resources together?
Look, I think when we developed the first one, which was, as I say, it was quite a long time ago now, we just made that assumption that a lot of people do, that if you build it, they will come. And then we worked out, actually, no, like everything, online resources are not for everyone. I think we definitely learned that during COVID, that people can get a little bit zoomed out, a bit technologied out, but it is definitely meeting a need. We have had really good usage from people who do sign up to the program. So for those that are looking for these kind of resources, they use them. They definitely tailor what they take in and out of the program. They don't necessarily absorb everything. We have some people who do use all of it. But yeah, I think we have definitely kind of learnt that it definitely meets a need. It's not for everybody, but for those that are looking, it does help. And we definitely know it improves quality of life and distress for those that do use the program. So I think it is actually, we know from research that these are good quality resources that will help.
So, I mean, you've talked about some structural issues as to what can stop people from accessing timely mental health assistance. I think we're all aware of those, but there's also sometimes people who are most in need of assistance are the least able to ask for it, or even kind of find headspace to admit it. Do you have any, I'm just freelance asking you questions now, but sorry about no warning, but do you have any advice for people who are desperately worried about a loved one who they can see needs some help but doesn't quite know how to incorporate it?
Yeah, I mean, look, it's a great question. I think quite often people that I've ended up seeing in clinic didn't refer themselves. They didn't know that they needed support. So sometimes it's actually about maybe their trusted oncologist or a member of their treatment team that's done a little bit of screening with them and just planted the seed. It might need to be even more than once about, have you considered that this, we have this psychology service that might actually provide you with a little bit of additional support along the journey. So sometimes it is actually about having someone else plant that seed and point them in the right direction. If it is, and as I think we already heard earlier, sometimes you get so busy in the practical, just get through the treatment, what's the next step, that you don't really stop to think about how you're travelling with it. So it might be that you need someone else just to, point that in the right direction.
Great. Thank you so much. Leslie, if you're still awake, yes. Excellent.
I am still awake. Could I just add
Yes.
something to that? I mean, one of the things that I like about the title of your programme is Finding Your Way, because I remember a patient saying to me that when she was told she had breast cancer, she thought she'd arrived in a strange land where she didn't speak the language and didn't have a map about where the hell she should go. And I think that's something that's really relevant, added to the fact that I keep meeting people who are not just anxious, but they feel anger at the well world, why me, and they need some help with that. Guilt Is it because I, ate the wrong things or didn't exercise? So it's more complicated, isn't it, than just dealing with the anger sometimes.
Well, I guess it's like anything that involves a huge new dump of information and threat. Your brain goes into this panic mode, trying to deal with it all.
Yeah.
But do you find, Leslie, that I was just interested that other Leslie talked about her worst days. I mean, the first day is the worst day because you know the least and you fear the most, I guess, right? So is finding out the answers to clinical questions in a manageable and understandable way a reliable path towards lessening fear?
Well, that's interesting, isn't it? Because you use those words, manageable way, because I think particularly in early breast cancer, patients often are overwhelmed by the desire to give them sometimes too much information. I often think that a woman newly diagnosed with breast cancer must actually develop a hernia, sort of carrying all the leaflets and various things away.
And another thing, yeah.
Yeah, and it's all well-meaning, but sometimes you do need, as this person has landed in this strange new world, a guide who doesn't point out all the museums and all the sort of best restaurants, needs to talk you through the basics first of all. Because half of dealing also with the uncertainty is feeling that you're in control of things. And people feel panicked by that loss of control. I don't know what to do next, what I should be doing. And not all of our clinicians are as good as people like Belinda at helping them navigate that path. So thank God for all the charities that try and step in.
And now that you can be awake at any hour of the day or night and explore your own anxieties online, what sort of an impact has that had to the proliferation of too much information and a sense of overwhelm?
We recently did a study of women with metastatic breast cancer, and one of the many questions we asked them was, what advice would you give to a newly diagnosed patient? And virtually all of them said, don't Google. Now, I think a desire to Google is often a reflection of them not getting satisfactory communication or sources of support in other ways from their healthcare professionals. But yeah, we live in an online world, and rather than actually search for more information, perhaps they should listen to a podcast.
Perhaps.
Or,
they're great.
Or some music, or direct them to things like relaxation tapes or things like that, rather than yet more information. Because the other thing is that if you are in this strange new world with this esoteric language, dealing with concepts you've never heard before, you'll find lots of contradictory information out there that's going to, instead of, helping you, confuse you more.
Okay, so we've talked about supportive care so far in terms of supporting patients, but you've done quite a bit of research into the supportive care of health workers and clinicians who are looking after those patients. What kind of challenges do these health workers face when caring for people with breast cancer, and how does it affect them?
The answer to that is that increasingly they're not dealing very well with it. Perversely, because we've actually seen so many advances in the treatment of breast cancer, we've got more and more people diagnosed with it. We've got more and more different sorts of treatment options, people living longer, and therefore waiting lists, throughput, cost containment with all the different drugs available. These are all things that doctors have to manage. And I think also it's a good thing in a way, but it's also a challenging thing. The expectations now are that you not only know all the best treatments, that you are efficient business managers, you're active clinical trialists, you're mentors for junior students and others. You've also got to be empathic and aware of everybody's sort of more holistic needs. That's a tall order for most doctors, and we know that dissatisfaction with the way that patients are treated is increasing. People are making lots more complaints than they used to. And burnout, compassion fatigue, moral injury, things that a lot of our doctors are now sort of experiencing. It's meaning that many of them are leaving, and that puts pressure on those that are left behind.
Can you just explain what moral injury it is? It sounds biblical, but I'd just love to hear
Yes,
you
it does,
outline
doesn't
it. Does,
And I'm
yeah.
not biblical, but yes, it does sound rather biblical. It basically means when you've been trained to do a job well, and you care deeply about people, and you want to offer them the best care, but the system is set up so that you know you're failing most of your patients day after day. That leads to moral injury, a guilt. I know I should have done better. I know I should have spent more time empathizing with that patient, offering them more overt support. But I mean, I'm curious now that I've become an apologist for the doctors almost in a way, because people used to think I was hypercritical of doctors, which is untrue. I love doctors. I tried to stay married to at least 2 of them. And a dentist. Demonstrating huge commitment to the cause. But on a more serious note, I think that unless we can actually help not just our doctors but also our nurses, because burnout is very common amongst them, and give them the sort of support that they need, the patients are going to suffer big time. And there are things that people need to do. Now, it's sometimes quite difficult for doctors and nurses to admit that they're in trouble and that they need, more help. Sometimes there are people who feel, you can't stand the heat in the kitchen, get out of it, When I was a young doctor in training, I had to do all this. You hear people still say that, but I think there's still a little bit of a stigma about people admitting that they're not coping very well and that they really require more help. There's also a blurring of professional boundaries that has occurred over the last sort of couple of decades. Patients can now contact their doctors more easily, use first names, sort of accept people as, friends on social media, and that all starts to sort of make the relationship somewhat blurred and expectations about it difficult.
Is that because there's no boundaries between when you're at work and when you're not at work anymore? I mean, does that contribute to burnout? Or
a little bit. An oncologist friend of mine told me that he was in bed one Sunday morning having a bit of a lie-in with his wife, and his FaceTime phone went off, and he thought it was one of the kids, and he answered and said hi, and it was a patient who had managed to get his mobile phone number. He didn't have his dinosaur onesies on at the time, which is something.
Sounds awkward in a multilateral sense.
Yes, but he was actually quite affronted and cross about it. But and you see actually sort of this happening. People giving patients. Probably COVID changed things a bit. People were anxious about people being able to contact them. I mean, you didn't have quite the same problems that some of us in the rest of Europe had with COVID, but access to help and people. I mean, people were giving out their mobile phone numbers, and that all contributes to never having downtime. I guess that's what we're really getting to here. You have to actually see the job of nursing or surgery or oncology as what you do. It shouldn't become who you are with nothing else, because you're never going to be fulfilled as a person or actually give the best to your patients if that's the case. So it's complicated. We've got to help everybody a bit more. Being in a good supportive team is often useful. We know, I mean, apart from the fact that you can get interventions to help you, like relaxation, cognitive behaviour therapy, all the things that we recommend to patients, that's good for doctors who are feeling burnt out as well. But the other protective factors, if you like, are working within a very good multidisciplinary team, a functional one. It's a bit bad luck if you're going to spend the rest of your career in a non-functioning one, but functioning multidisciplinary teams help. And also, we have got evidence that attending an evidence-based communication skills training program will help protect you from burnout as well. So that's
Sounds
why
like homework.
it's why I haven't retired. I'm going to work forever.
So that question about multidisciplinary teams, does that, I'm just thinking about these themes of overwhelm and too much information, do those teams, when they work well, are they about the oncologist, for instance, understanding every single technical detail about what the other people in the equation are doing, or does it involve just a high level of trust and consciousness of their role?
Well, actually, you've really sort of hit on something that personally my team have been very worried about for some time, which is that teams need to be aware of the informational roles that their colleagues serve. You obviously have chosen to be a radiologist, or for some reason a pathologist, or a surgeon. Sorry, there's no pathologists here.
Oh, they'll hear about this.
Obviously, one has to have a basic awareness of what sorts of treatments, diagnostics, etc., are going to be talked about and offered by different members of the team. But who should be the person to actually explain it in detail to the patient is an interesting thing, because we examined across multidisciplinary teams, not just breast, all tumour sites, key areas of information, and we asked people in the team, is this your responsibility to talk to the patient about? If not, who in your team discusses this with them? And it was just a complete mishmash. Patients were falling through huge informational gaps. Everyone thought that the nurse should be talking about sex, vasomotor complaints, the surgery, the after effects, the emotional fallout, and not all of them were doing that. They had other things to do. But one of the things that we helped teams discover was where they were also all doing too much of the same thing, and nobody was covering the key things that patients needed. And I think that sort of work is quite important.
It just sounds like a household, doesn't it? You know, where
does.
everybody thinks, I do so much work.
And no one cleans the lavatory.
All right, we'll park that thought, because well, don't. I mean,
Sorry.
yes, no. The pathologists are going to be so concerned. It's
Sorry,
not
pathologists.
rescuable.
I love you, really.
Have you married one? Never mind.
No, no.
So, Cindy, I'm going to bring you in here. What role does your area of expertise in nutrition and exercise play in supportive care for people with breast cancer?
Well, my background is a dietitian. I'll start with the diet first. So nutrition obviously is a fundamental thing. So to support everyone to get essential nutrients so that they to normal body function. And certainly healthy eating is something that everyone knows, and the benefits, health benefits, is actually out there with in terms of the data. We have also a lot of people who have a lot of diet and cancer myth, and so that's where the nutrition or dietitian comes in to provide that information so that people actually can make informed decision and actually choose what they want to eat, but make sure that during that decision makings and knowing what they actually are not missing out essential nutrients. So in terms of the, we also have research data to show that eating the healthy diet can improve health quality and also reduce the risk of cancer recurrence. In terms of exercise, I have to say that my exercise physiologist colleague has finally caught up, because over the last few years, we have a lot of health data coming out and saying that they are actually beneficial during the treatment time, help with the symptoms. And certainly, I think probably you guys would have seen the TV, we have a challenge studies, which is obviously not on breast, but really looking at the structural exercise for patient with colon cancer, and for 3 years after that, and the data come out and has been really good comparative to drugs in reducing the cancer recurrence as well as the survival. So I think they are very important. Everyone knows about it. I think the question is how they do it.
Okay, so I mean, I'm pretty sure that everyone who's had a cancer diagnosis at some point has had a cousin drop around with a bag of chalk because they know somebody that knows someone who just ate chalk and everything was fine. I'm making that up, obviously, but I mean, there's a lot of direct, lived or indirect conveyed experience that perpetuate myths and misconceptions around diet in particular. Are there some that you see turning up that make you particularly roll your eyes and you think, here we go again?
Yes. There are many of them. I think the two common ones that I come across, it pretty much apply across all tumor type, was sugar feeds cancer, so I should avoid sugar. The other one, more specific to breast, would be the soy products. So just for the diet and cancer myth, basically, at this point, long story short, is there's no evidence to suggest that sugar actually causes cancer, direct link. Certainly, there are a lot of evidence to say that if you have a lot of sugar in your diet, that likelihood to increase weight, and we know that being overweight or obese increase the risk of cancer recurrence or cancer diagnosis. Certainly, being too heavy, that's not very good with basically mobility as well. But in terms of the soy products, it's the same thing. We are really talking about having a small amount as part of a healthy diet. We are not talking about like soy supplements. So there are a lot of Asians out there. So soy products, tofu and things is part of a healthy diet, and they are doing pretty well.
Where did this soy thing come from?
Because of phytoestrogens and obviously with the hormonal sensitive breast cancer, that's one of the concerns. But the actual amount that people consume in the daily diet, especially in Australia, is really not that high. So generally speaking, as part of a healthy diet, it's actually fine. Unless you are a vegan, where you actually drink a lot of soy milk, where you have a lot of tempeh and actually tofu as a main source of protein, then that will be excessive amount. Then that's a really different story.
Okay. It normally just always comes back to eat colourful vegetables, doesn't it? I mean...
Yeah, so I think the quantity matters. So a lot of people say, oh, we have tried to incorporate different variety of vegetables. But if you say one piece of corn, 1 carrot, 1 slice of tomato, there are 3 types of veggies, but the small amount, that's not quite going to make it. So I think the guidelines is really trying to get an adequate amount. So for Australians, we actually recommend for 5 serves of veggies and 2 serves of fruits. A lot of people kind of know the fruit and veg are very important, but certainly trying to achieve that can be challenging, especially during treatment time.
Yeah, particularly when every day you have to start again.
Yes.
Could you just tell us a bit more specifically about your clinical fellowship project, which is around lifestyle innovation?
Yes. Certainly, how it started about is that I see patients after they finish the treatments. A lot of times when we actually observe how much exercise they do and what sort of food they're eating and how much weight changes they have since the diagnosis. And generally, when I see them, it's approximately 1 year after the cancer diagnosis. During that time, what they do, what we found that many of them are actually not doing exercise, certainly not following the guideline. When I say guideline, I'm referring to the exercise guidelines where we say 150 minutes of moderate intensity or 75 minutes of vigorous intensity types of exercise per week, and 2 or more sessions on resistance exercise. So 1/3 of our patients manage to meet the aerobic types of exercise, but certainly not the resistance exercise. So on top of that, a lot of people make dietary changes. So our study found that when the women come through the clinic, actually average dietary changes will be 2 per person, but it can go up to 7. Some of them actually are very good dietary changes where they eat more veggies and fruit and try to improve their diet, but also including the dietary changes such as avoiding the meat or red meat all in total, or avoiding all the dairy products. So I guess that just show that not all the dietary changes are beneficial and not necessarily evidence-based. So we think that bring the interventions like exercise, promoting the eating earlier, right from the beginning, may be beneficial. So we're running a phase 2 or pilot study online, trying to recruit people during the treatment and say, please come on, we give you diet and exercise session supervised by the exercise physiologist, trying to promote that activity. Because a lot of women are actually doing very well before they start the treatment. But somehow after cancer diagnosis, obviously, if a life-changing events, people stop working, things change. So the eating and exercise sort of drop to the bottom of the list. So we're hoping this kind of programs can promote that or support people continue doing exercise and healthy eating. Those who stay on, we have a lot of interest. We actually managed to close the study very early, quickly. A lot of people interested sign up, but I think about 40% of them actually drop off. So we have 60% of them finish, and they actually have some promising results, which we are submitting the paper. But the 40% of them actually not finishing the program. So I guess that's where I would like to use the opportunity to explore why actually people, first of all, those who did not sign up, why they did not sign up for the programs. If they do sign up, what they find it very challenging for them to continue on. Is that just the timing of the intervention not appropriate? Or more like there are other external factors that we can help to support them.
Great, okay, thank you for that. I'm going to do a handbrake turn to another clinical fellowship project. This one is being conducted by CAF, and I read the name of this practice that you're investigating and promoting. It's called Deep Inspiration Breath Hold. And I must say, when I read that, I thought, okay, this is something to promote well-being and a feeling of calm, and just feeling a bit more cruisy about things. Is that what it is, or is it something clinical? Great,
Yes,
wrong.
it is
Okay. Would you care to explain, please, what it is?
Sure. So for our left breast cancer patients, we ask them to take a deep breath in and hold their breath. So that basically displaces their heart away from their breast, and it is one way that we can reduce cardiac dose from their radiation therapy treatment.
Okay, so you need people to be able to hold their breath in a deep way so that their heart can be further away from their breast.
Correct.
While they're having a scan or...
So while they're having a scan, first of all,
Yep.
that scan is a preparation
Right.
for their treatment, and also while they're having treatment too.
So the radiation, it protects the heart if it's further away from the boob, is what you're saying? Sorry, I'm not an expert. People.
It reduces the dose.
Okay.
Yeah. But it's one way as well. It's not the only way too. And we have to be very clear about that to patients, because some patients cannot take that deep breath in and hold that deep breath the way that we want them to hold that deep breath for
How deep
treatment.
are we talking about and how long? I mean, are we talking pearl diver or just person who hasn't just run upstairs?
So no, at least 20 seconds. That's the minimum that we ask for.
Is everybody doing that right now?
And everybody is doing it when they're sitting up as well, so it's not actually representative of...
how do
when you're lying down and your
Yep.
arms are above your head as well, so it's completely different. Yeah.
Okay, so how hard is it for people? I mean, it's one thing for us sitting here to just think, yeah, I reckon I could do that. But when you're lying down, also when you're nervous and
Yeah.
you're not sure what you're,
Yeah.
you know, you're being rolled into some sort of tube, it's not conducive to breath holding in a calm way either, right?
So, you know, when you're anxious, right, you feel very breathy. We've had a number of chemotherapy patients, which I'm sure you have experienced as well, where patients say that they feel quite breathy from their treatment. I know we've had some patients, one said that from chemotherapy, that she felt every side effect. She had every side effect that was possibly mentioned to her. When I asked her to take a deep breath in and hold, she said it felt like her lungs were on fire. So, you know, those things. Breath fitness goes down with chemotherapy as well. When you asked about how deep a patient needs to take a breath, it needs to be deeper than their free breathing. So even a centimetre deeper will have an impact.
And moving the heart, isn't that incredible? Okay, so how do you help people train to be able to do that in the moment?
Yeah, so we coach patients. Now we do have a screening program as well at Lismore. So basically when they see a radiation oncologist and we assess their breathing, we'll coach them with that. And yeah, we see that there is potential for them to do deep inspiration breath hold. We'll give them virtual reality education on the treatment technique.
This brings us to your toy that you brought with you. I've been eyeing it and hoping that we get to have a chat about it. So, okay, to me, I think breathing's here. How does this help?
Yes, so there was quite a bit of research done on this. So we did interview patients who were able to do deep inspiration breath hold, who were unable to do deep inspiration breath hold as well. And they told us what they wanted. So, you know, when Leslie talked about communication and education before, health professionals sometimes can communicate to patients in a way that isn't received well by patients, and we don't know that sometimes as well. We
Listen
just
how
think
careful she's being. She's being very careful.
well, we think we're communicating in a way that they understand, but sometimes patients don't understand. And you can see that as well. You just get patients who give you a glazed look, and you know that you're not basically penetrating to their understanding on the matter. So with film, as you know, basically it's meeting a need, and it's very much in lay terms as well. So we're not talking in esoteric terms. You know, I was saying to a friend of mine and having a bit of a laugh the other day, looking at some radiation therapy patient education, and I said, you know, this was written by radiation therapists for radiation therapists. It wasn't written for patients at all.
So is the VR about just showing patients what it's going to look and feel like when they're undergoing this procedure that might be the first time they've ever experienced it?
Yeah, that's exactly right.
Right.
So a lot of patients...
What a cool idea.
Yeah, they only have radiation therapy once.
Yep.
They haven't, you know, surgery. People know what
Yep.
surgery is, radiation therapy.
So that sounds scary.
Yeah.
Radiation therapy just like, it's got a branding issue.
It really does.
Well, no, just like the word radiation just, it doesn't sound great. Like it doesn't sound like it's going to be fantastically
Yeah,
fun,
yeah,
right?
that's right. And
Yeah.
then, you know, people sometimes latch onto that and give misinformation as well had many patients who say, I have decided to not be around my grandchildren because I am now radioactive. We're like, no, you're not at all. And then have to explain that to them too. So with a virtual reality, we basically are simulating their mapping session when we're preparing them for their treatment, and then simulating their treatment session as well. And we give them coaching as well. And
My next question is, can I have a go?
sure.
Thank you.
We have practice casting this.
This
so,
is going to go super well, and it is, even though a piece of technology is touching me, it is still going to work, which is not always the case. So I'm going to put this on my face,
Yeah.
and
I'm gonna try and
then
control
you're all
it.
going to be able to see what I can see, right? Okay. I've got
Hopefully.
big hair, so just, yeah. All right, okay, I'm in the room. Is everyone else in the room?
No.
They're bored.
Kath, I mean, I'm relying on you to pick. There's
I'm
your
trying.
disembodied hand. Fantastic.
Okay.
All right. So I mean, this is wild.
So
Like,
let's just see if we can see that play button. There it is.
Yeah.
Okay, if you could stay still just for a moment, I'm
I'm
going to
sorry,
go
it's a very big
there
ask.
and hit play.
okay.
And then maybe I'm going to have to hit play again.
See, if I were a functional person, I'd be doing all this, but I've got Kath helping.
Okay,
Great.
So just
There we
breathe
go.
normally
All
for
right.
me.
So here we are in
Try
the
and breathe
room.
normally for me for a little bit.
Hi, Kath.
Just take your breath
So when I
all the
told
way
you
back
guys
down to
before
that
about
blue
lying
line.
on your back and with your arms up, that's a typical way of how we set up patients. So this patient in particular has goggles
Okay,
on,
when you're
and
ready, take
that
that
yellow
big, deep breath
line
up to
is
that box.
represents her breathing.
You to hold for 15 seconds.
And then we want her to hold a deep breath into that box and just hold it in there.
Okay, that's 5 seconds.
And we count down.
10, 3, 2, 1, and relax.
Okay, so just try and get your breath back there.
So with this video, we're basically going through a whole mapping session with the patient.
We'll just get you to
So
breathe normally.
there's pluses for this. A lot of our patients just walk in and they know exactly what they need to do straight away as soon as they go in. So for us, with resourcing, for example, that burden has been decreased quite a bit, and they can ask us other questions as well. So some patients do have anxiety because before,
Okay,
if they
whenever
don't
you're
know
ready,
what they're
take that
going,
big deep breath
what
in,
they're going
hold it
into,
in that box.
they would just come in and we would say, okay, now we need you to take a deep breath in and hold your breath and hold it in this particular way. And a lot of patients, well, many
Okay,
patients
that's
will
10
get
seconds.
quite anxious from it. We had some patients who were quite distressed as well, and they would be
15,
crying through this whole process, and it would be,
2,
distressing
1,
for us
and
to
relax.
see them go through that. Okay,
That is so
So-
cool. Sorry.
I'll just hit pause on it.
Oh gosh, yes, I'm really sorry, everybody.
You're right.
I was trying to make it not all about me, Leslie, but isn't it interesting though, because you can explain to somebody using words what a
Exactly.
circumstance is going to be like, and if there's 60 to 80% of their brain pan is just, help, oh my God, I'm so nervous and scared, then sometimes it just bounces off. And even just instructions like, please wear loose-fitting trousers and a separate top. You know, when you see what's happening, you're like, oh, that's why I need to do that, right?
Exactly.
It just demystifies things.
That's exactly right.
Okay, so what is your research showed about how useful this is to achieve the clinical outcome that you're looking for?
Sure. So a lot of patients now come to us and say that their fear of the unknown has been completely obliterated. So they know exactly what they need to do. So the anxiety is reduced as well. So in our pilot, we did have a statistical significant difference showing that anxiety had been reduced from the virtual reality education. Yeah.
So does the deep breathing help with just moderating anxiety as well as bringing about the clinical or physiological outcome that you're looking for?
Maybe.
I'm obsessed with that. This is about meditation.
Yeah. So, who was it? You, Leslie? I think that was talking about control. So we've had many patients say to us that they, and sorry, Lisa, say to us that they felt in control from doing this, because basically when they take that deep breath in and hold, that's only when treatment is activated. And so many patients said to us that they had no control in their whole pathway until they got to that point, and they knew that they were controlling the beam and they had something to do with their treatment as well. So that was really good.
I guess when you're feeling panicky and you lose your ability to regulate your breathing, it's a bit of a slippery slope, isn't it? I mean, you really, it is about loss of control, isn't it, in a basic sort of animal sense?
Well, definitely, and I think sort of when you're undergoing treatment, everybody is doing stuff to you. You know, you're sort of, you become almost like passive, and yet it's scary because you've got a life-threatening condition. So even something that sounds quite small, like being able to control your breathing and know you can do it, that sounds to me therapeutic in itself, actually.
Okay, thank you. That was absolutely fascinating. I'm going to be thinking about how to move my heart further away from my breasts, probably for longer than is sensible. I'm going to come back to you now, Belinda, because we have a question from Kate, who's asked if you could explain how the ProSigna test works and how it's being used in the Optima clinical trial.
Sure. So the ProSigna test and the Optima clinical trial are for people that have got hormone receptor positive, HER2 negative breast cancer, which is the most common type of breast cancer. And so the main treatment for hormone receptor positive breast cancer is actually hormone blocking tablets. And patients who have got a higher risk of their cancer coming back also receive chemotherapy. But we don't really have a test to work out who really needs that chemotherapy and who can be safely spared the chemotherapy. And so ProSigna is one of a few tests that have now been developed that analyse the actual tumour tissue. So after someone's had surgery, their tumour's been removed, a sample of that tumour can be tested, and the ProSigna test looks at 50 different genes in that cancer, and it helps to quantify the person's risk of their cancer returning. And that then helps us work out whether or not they should have chemotherapy. So if they have a high risk cancer, then I would like them to get chemotherapy with their hormone blocking treatment. But if their cancer's low risk, then they're unlikely to benefit from chemotherapy, so they can just be treated with the hormone blocking treatment. So in a way, it's a method of sort of personalising the treatment more to work out who really needs the chemotherapy and who can we spare from having the chemotherapy. And the reason we want to do that is that chemotherapy has a lot of side effects. So if we can try and be better at working out who really needs it and who doesn't, then we can save people unnecessary side effects.
You've done one of these Q&A sessions before about this increasing movement towards personalised care rather than just hit it with everything we've got, team, which are the expectations of patients changing in that regard in your experience? Do you still encounter people just like, okay, get me a section of horse brass and hit me with the works?
Yeah. Definitely. You see a whole mixture of people, but there are certainly those people that come in very scared and have heard that you should have chemotherapy. And so I want to do everything I possibly can. So sort of talking about maybe not having chemotherapy is only going to increase their anxiety. But there's other people that their biggest fear is chemotherapy. And so they want to do anything they can to avoid it. So if we've got a test we can do to say we actually think it is safe for you to avoid it, then that's really helpful.
Oh, amazing. Okay, thank you. I'm going to hit you with another question straight up from Heather, who would like to know how supportive care can help patients with metastatic breast cancer.
Great question. So I think metastatic breast cancer is really when breast cancer is spread to another part of the body, and other terms are for it a stage 4 breast cancer or advanced breast cancer. And we are now seeing most of our patients with advanced breast cancer living many years. So these are women who are living with their cancers for many years. And so what we need to be doing is trying to do everything we can to help those years of life that they have be the best possible. So how can we support them? So I think, like we were saying before, with all those different sort of aspects of supportive care, so the diet, the exercise, minimising side effects, they are just as critical for people with metastatic breast cancer as early breast cancer. I think with metastatic breast cancer, there's a few unique features. I think the cancer is usually going to be incurable. So I think there's a whole lot of questions and support needed around how long am I going to live for, around prognosis. Getting involved with palliative care early is really helpful in terms of with managing symptoms, preparing for the end of life, thinking through sort of what you want at the end of your life and decisions around that. So I think palliative care plays an important role with the metastatic patients when we're thinking about supportive care, in addition to all the other things. Fear of cancer progression, and often, like we were saying before, that's another real anxiety. And then the whole scan anxiety, what can we do to help? Most of our patients with metastatic breast cancer are on treatment forever, and they're having scans forever to check how those treatments are working. So there's a lot of support we need around the anxiety of that, and making sure when they're on treatment forever that we're minimising the side effects to maximise their quality of life. So it's really maintaining the quality of life of our patients who are going to live many years.
Can I get you to weigh in and just with your reflections on that? I apologise for rudely being on my phone. I'm just trying to find the last couple of pages of my questions, which are not with me. So I'm going to jump to you for a second.
Well, going
Thank
back
you.
to, sort of this issue about assuming some sort of control, we hear a lot about shared decision-making now and patient centricity. Everybody's meant to be much more patient-focused. But patients can't make informed choices about things and assert some control if they haven't been given information in an understandable way. I love the way that Belinda just described what a gene expression profiling test is, looking at the genes inside the cancer cell, not the genes that give you your hair colour or your eye colour. And we ran some courses to help doctors, because in Europe we've had these tests available for much longer, and we've had quite a bit of experience with them. And we ran courses to help doctors explain the importance of the test and why chemotherapy might not be necessary. And although we saw some improvements in the way that the doctors described things, there was still a lot they needed to do. And we thought, well, hang on just a minute, we're missing a mark here. Shared decision-making is a two-way exchange. What can we do to help the patients become more involved? And so we've made 7-minute user-friendly information videos, all freely available on YouTube, in French, German, English, Urdu, Hindi, Gujarati, Bengali, loads and loads of languages, that help the patient, before they see the doctor, understand what the decisions are that they're meant to be making. And we then did a randomized trial to see whether or not patients genuinely did feel more in control, more power in decision-making if they had the film. They either got standard information or standard information plus the film. And what happened? The doctors said the patients who'd had the film asked less weird questions and, well, that's the polite way of describing it. And also, the communication, the length of time that they spent with the patient was shorter because the patient knew what they were talking about. So I think we've got a long way to go to, I mean, support is not just helping people with symptoms of things. It's helping them make wise decisions that fit in with their own preferences for things. And I think we can do an awful lot more about our communication to spare them some of the anxiety, some of the uncertainty that they have.
It's interesting that we keep coming back to these themes around information and feeling in control, or feeling at least that you know what you're moving into, which is, of course, what your VR headset's all about, and not feeling when you arrive at this moment as if you've somehow failed as a patient because you can't hold your breath for 20 seconds when you've been asked to while you're lying on your back in a machine and feeling freaked out. I am going to go across to you now, Lisa, because we have a question conveniently from another Lisa who says that she's experienced, this is talking about once you've moved from the moment of crisis, it doesn't necessarily mean you stop needing supportive care, right? Lisa says that she's experienced feelings of being alone, lost, sick, exhausted, and confused in her breast cancer journey, and she wants to know what help there is in being able to live again and thrive after breast cancer.
Yeah, and it's an interesting one that I've had the conversation so often that people often feel like they're only starting to process the impact of their cancer once the treatment's finished. So during treatment, they're just so busy doing it, and it's really only afterwards that they stop and kind of go, gosh, what just happened? But it is really, I guess one of the things I would say is it's really quite normal. It doesn't mean it's great, but it's really quite a normal thing for people to feel like their whole world's been upended and not quite sure who they are anymore or what they actually want to do with their lives, what they want it to look like. So feeling isolated, feeling alone is actually quite a normal thing to experience. And then I guess the key thing is around how do you actually start to reintegrate and start to form a new normal of what their life is going to look like after cancer. So in terms of some of the options there, I think there are quite a few really good support organisations, community organisations. You can get in touch with things like the Cancer Council. They'll often be the great referral hub that can provide options for support groups that might be really great for providing connections. Breast Cancer Network Australia, again, they can provide really amazing resources and direction of where to head. For those that are really finding that they're a little bit stuck with getting started, it might actually be worth reaching out to a member of their treatment team or to their GP to get a mental health care plan or to see if there's a psychology or mental health service within their hospital-based psychology or a psychologist in the community as well to help them get some strategies on board to get started with that reintegrating in life. But I would often say one of the key starting points is that people will often wait until they feel better before they start
Really worrying.
Yeah, or before they start doing more, that they're not going to start doing any of their activities or return to work, for example, if they've stopped until they actually feel better. But what we do know is that sometimes just setting some gradual activities and goals for themselves, they don't have to be big goals, but just getting things started is actually the process of what helps them feel better as well. And those things can be, I often will suggest looking at trying to set 4 different types of activities. So whether there's one that's like a physical activity, some gentle movement can actually really help. We know that can help lift mood a lot, as we've already heard today. Whether it's a social activity that will help with that sense of isolation and connecting with others. Doing something that gives them a sense of achievement and purpose. So ticking off something that they've been putting off for a while can actually really help to lift mood as well. And then lastly, just doing something purely for fun and joy. So they're kind of the 4 key things that I'll often help people just with getting started again.
I guess maybe another takeout for Lisa from what you said is just that these aren't necessarily permanent feelings, right? You can move through them and there's not a right and wrong time to be feeling them.
Exactly right, yeah. And I think the key thing is it's about recognising whether it's getting to the level where it's causing significant distress, where it's actually interfering with your ability to function or really causing a lack of or a loss of joy in your life. So if it's getting to that level, then it is really important to take action and not to sit with it forever.
Great, thank you. Leslie, I'm going to throw this question from Nicole to you. She's asked, what are the best strategies for dealing with scanxiety once treatment has stopped? I'm figuring you've seen a lot of scanxiety in your time.
Yes, well, I mean, again, it's helping people learn how to deal with uncertainty because, to a certain extent, doing all the lovely things that you've just recommended patients should do to relax and, feel more in control. That's terrific, but it's also a displacement activity for what you're really worrying about, which is what will the next scan show? I think that one of the things that we all need to focus on is that anxiety does have a useful service. You know, the only reason we feel anxious is because we need to be alert to things. So getting rid of all anxiety is not where it's at. And I think sometimes actually it's appropriate for patients to have a little reminder about the work of worrying. Okay, the reason I'm having this scan is to see if there is a recurrence of my cancer or if the drug is actually shrinking the tumour. That is important because if it is, it means that I now have to do something different or I'll get reassurance. So when I deal with people who've got a crippling anxiety about going off to have another scan, I try and actually get them to focus on, you know, there are two outcomes from this. Either they're going to show that the cancer has actually moved on a bit and they need to start further treatments or different treatments, which is a good thing, or they're going to tell you that the current treatment you've had or you're experiencing at the moment is actually working well. That can sometimes motivate people to adhere to drug therapies as well, take their pills. So I guess sort of eradicating all anxiety is A, not possible, and B, not always sensible, because patients have actually got to be aware that, you know, it could return.
And do you think that the process of slicing and dicing it like that kind of reduces this sort of overwhelm that is the symptom of really crippling anxiety, when you're not really, you're just scared of everything?
Yeah, absolutely. I mean, some people are constitutionally just anxious about anything. Will I actually catch the bus? Will I make my connection? You know, life is full of uncertainties that cause anxiety. And I guess sort of, as I've said, sometimes it is a prompt to act appropriately, so can be useful. It's the crippling anxiety that actually stops and prevents you from doing anything that is the worst thing. I noticed the other Leslie nodding away there. And
Leslie's got things to say, I think.
Yeah,
about...
I'm sure she would, yeah.
Well, how do you manage your anxiety about recurrence, for instance?
I put it in stages. So like Lisa said, when you're on treatment, you're just hoping that the treatment's working. So there's a level of anxiety there, I guess, attached to fear of recurrence or whether the actual treatment is working, which is a bit of an unknown in some cases. So there is that level of anxiety. But as I said, because I was on a trial, I started doing the patient-reported outcomes. So at 5 years when my treatment stopped, for another 10 years I could still report how I was feeling about that. So that was really beneficial. But then there was a level of anxiety after I came off treatment, but because that flagged by my team, I didn't see a psychologist, but I just saw my breast nurse in the clinic, and we talked through it, and she basically changed my mindset to look at it like Leslie Mark 1 said, and that would be, you don't know what you don't know. So there's two outcomes. Either we get, if it has advanced or if you have got metastatic disease, we've got it at the early stage, so it can be, you can go on to treatment again, or the treatment's worked to date, and so you're free to go for another 12 months. So I think I then ended up changing my mindset around to being more positive about scans, as in I want to know that it's still working.
It's interesting. I mean, you've talked a couple of times about this sort of reassurance of having this system of a structure around you and to check in and be asked how you're feeling as a matter of routine. Are there ways that people who aren't on trials can kind of reproduce that system of a structured check-in, even with themselves or with families or with other people, where you actually take time to objectively ask yourself how you're feeling right now in this moment?
Look, I think things have got better in clinic because we've got oncologists like Belinda who do approach patients and ask them about their supportive care needs. and we have obviously other supportive care clinicians that can help. I think from my perspective, I feel like in clinic now there is a lot of that goes on, and GPs are obviously across that too, because GPs are afforded all the information that the multidisciplinary team gets, so they know how you're travelling, so they can also raise things with you. When it comes to family, I think that's an individual thing. Mm-hmm. Some families can be very supportive. Other families can increase your anxiety. So I think it's where you get your information from is really important, and your access to that support.
Great, thank you. We've got another question that I'm going to shoot to you, Cindy. It's from Helen, who says, how do you manage food cravings?
Yeah.
Because appetites change depending on where you are in your treatment cycle, right?
Yes,
so
certainly.
Do you see a lot of this, people's relationship with food changing?
Yes, certainly. The steroids doesn't help either. When we talk about food cravings, I think my first question probably would be asking, some people do say, because there are many factors affecting a person's food choices and food cravings as well. I guess my question probably will be asking, is it something because of a hunger, or, because often people say, could be lacking something in the diet. But often when you ask people what they crave for, they usually go for something that sweets are more towards the comforting eating kind of like types of food. So often that more related to the stress. So what I probably would say that is it's important to identify the underlying reasons for the cravings. If it's purely say that 8 o'clock, because I have my dinner at 5 o'clock, by the night time at 11 o'clock, I'm actually hungry, I really want to eat something. During winter time, I want something very hot. I guess those kind of cravings, you can say that because it could be a reason that you have dinner is too early and it's actually not enough, because we know that often 4 to 5 hours is when people are starting to feel hungry again. But if the cravings or you're actually looking for food is because of stress or because of boredom, then obviously the strategies to deal with it would be very different. So we actually not suggested by few of the patients, they often find that late night snacking or craving for something is because it wasn't because they were hungry. One of the things is they were routine, or second thing is that they were bored. So I think this is where we think about, like, let's say, talking to our friends just to have some sort of distractions can help. Certainly, if often nighttime is a time that people crave for something, having a planned supper is a good way to actually ensure nourishing snack as well as less nutrient dense or energy dense to prevent weight gain.
Great. Okay. I've got another question too from Christine. Now, I know we've talked about sugar and soy and a lot of myths that run around the place. Christine wants to know, though, are there any food or exercises broadly that she should avoid while going through breast cancer treatment? It's an unfair, question to ask you in such simple terms, but...
Yeah. So, I asked my exercise colleague about this, and certainly the consensus is straight after surgery. Obviously, you don't do heavy lifting and things until you get it cleared from the surgeon. This is when I say the exercise is beneficial, usually after treatments or during treatment as well. This is when I would encourage people to speak to an exercise physiologist or their physiotherapist to actually ask for recommendations. There are a lot of actually useful websites to show that what types of exercise can be done. So it doesn't have to be upper body. And when we talk about exercise, it doesn't have to be like gym sessions kind of situations as well. So in general sense, is there's no restriction unless your surgeon told you so. In terms of food-wise, I guess critical thing is really about food safety during treatments. So obviously, immune system is being impaired during the treatment time. That's where the listeria risk is high. We often say, sushi is great, sashimi is great, but that probably is not the best time to have them. I guess the soft cheeses and those other things that we ask people to avoid. But that's purely coming from a food safety point of view. Other than that, generally is that to plan the food well and know what other things they like or they don't like. If there's no personal allergies, certainly I don't think there will be anything should be avoided during that time.
Great, okay. Now I'm racing against the clock, so I'm going to go to you, Kath, and ask a question from Christine. Not sure it's the same Christine or a different one, but wants to know, how can we make sure that patients in regional areas can access supportive care services?
Yeah, good question. So a lot does come down to the system. I'm quite lucky, I think. I do work for New South Wales Health. They have invested quite a bit in rural and regional areas for supportive care. So with my project, for example, I was funded by our hospital, I was funded by New South Wales Cancer Institute, New South Wales Regional Cancer Research Network, and New South Wales Health also has the Rural Research Capacity Building Program as well. So you do have a lot of clinicians who know the issues in regional areas, which are very unique to rural regional areas, and to have some investment into those clinicians to do research and to do project is paramount. So a lot of people who work in regional and rural areas, they want to be there and they are advocates as well for patients too. So
it's a great point that they have differing issues from urban patients. While I've got you, Cheryl's also asked about radiation treatment, is worried about what impact it might have on her skin as well as making her feel fatigued. Any views on that or recommendations?
Everyone's different. The radiation oncologist will always tell you the worst case scenario. Different sites have varying degrees of skin erythema and fatigue as well. So going back to nutrition and exercise, I would definitely get patients to have to exercise as well. I'm not an exercise physiologist though, but we know about energy levels, and the Clinical Oncology Society of Australia has recommended exercise for cancer patients to bring their levels of energy back up as well.
Great. Okay, well I think across this session, apart from the recurring theme of control and knowledge and a sense of lessened anxiety that comes from knowing what you're moving into, we've also been reminded again and again that every individual's circumstance is different, and the sort of things that make them feel anxious or feel well can vary by circumstance, geography, character, personality, all the rest of it. Leslie, I really feel like it's important to come back to you as the last voice in this discussion. And again, it's an unfairly broad question, but if you could give any piece of advice or recommendation about accessing support services from your perspective and experience, what would it be?
So I guess like I mentioned before, having a good supportive care network is great, but it's where you get that information from and access to those areas. And sometimes family is good, sometimes not. I feel like it's like, when you're pregnant and everyone has a bad story to tell you, I feel like that's the same when you have a cancer diagnosis.
Right.
And everyone is different. Everyone reacts differently. Everyone has different needs. So I would say talk to your team first and foremost, and they can direct you the right way. There's a lot of places. BCT have lots of resources that can be of help. BCNA has been mentioned before. They have lots of resources, Cancer Council, trusted sources not Dr. Google. And so you would get those recommendations, hopefully from your team, where to find that right information that might be able to help you and help navigate that unnavigated path, I guess. And as we've all heard, there's so much work going on in supportive care, and quite often supportive care trials can be, you know, post that initial diagnosis or surgery or treatment. So get on a trial, I say.
Yeah, I think one thing I've really picked up so clearly from this discussion too is I think sometimes people are anxious about asking for help, or they feel self-conscious about being needy, but actually getting the right kind of help makes it so much easier for the clinicians around you to help you in the most powerful and economical way, right? Which, I mean, all of you along this panel have done great and different work towards achieving that outcome. So I hope that that's a message that is really pulsing out of this panel tonight towards everybody who is looking to it for advice and support. We are out of time, I'm sorry, so I would just quickly love to thank our panel, Lisa, Leslie, Kath, Leslie, Belinda and Cindy, and remind you that this session will be available and sent to you as a link tomorrow. It's been recorded, and remind you that breast cancer research runs on a lot of support. So if you want to be part of that support, head to the website and help out. And thank you in particular to people like Leslie who help out by sinking their own experience and learning into helping research be more effective. And finally, thank you to everybody who sent in questions and who joined us online or, in fact, in person tonight. Thank you and good night.